Thanks, Jen. And first of all, I just want to give everyone a big thanks for coming out on an evening to share with us some information on COVID. It's hard to believe that it was just a little over a year ago that the first COVID diagnosis was made in London at the University Hospital. And here we are a year later, storming through this pandemic with some light at the end of the tunnel with vaccinations. With that in mind, I don't want to take too much time, briefly just reviewing our agenda. We just going to have a quick little update from the London Middlesex Primary Care Alliance. We have 3 speakers who are each going to do a short little presentation on their various topics, which I will introduce as I introduce the speakers. Then we're going to have about a 20-minute sort of discussion. We're trying to get some of the questions that come up through the evening. As Janet mentioned, there was a number of questions that were submitted during the registration. Recognizing that we only have 20 minutes and we have the ability to people to answer the questions, we definitely will not get to them all, and we apologize for that in advance. But I'm going to try and choose the ones that don't seem to be covered during our talks and that seem to be quite relevant, and I think that have had repetitive type of questions. And then at the end, towards the end, we're going to do some breakout rooms where we are splitting people up. We are going to have 1 rural-based breakout room and 4 urban-based breakout rooms. So given that we are right now at 100 participants and we had 185 people register, so there still could be a lot of people joining shortly. That's why we had a number of the breakout rooms. And lastly, I just want to thank my Primary Care Alliance members who've stepped up to sit on our primary care vaccination task force, who are going to help us with moderating the panel questions tonight and the small breakout rooms. That includes Dr. Phil Vanderwall, Dr. Julie Clark, Dr. Mario Alia, Dr. Vineet Nair, Dr. Kathy Falls, Dr. Dan Pepe, and Steph Foulette. So thanks for that. So first of all, I'm going to introduce Dr. Vineet Nair. Vineet is a family physician in London here. He works in a small FO on Richmond Street, and he is working with me together as the interim leads or interim primary care representatives for the Western Ontario Health Team. And Vineet's just going to give us a bit of an update of some of the work that's ongoing with the Primary Care Alliance. And so we'll just give him a few minutes to speak about that. Go ahead, Vineet.
Great, thanks, Gord. Yeah, so I'm here kind of to talk a bit about the London Middlesex Primary Care Alliance, and just to give a bit of a background on that and who and what we are. And really, we are you and we are us. Like, we are the primary care providers in London Middlesex, and that's what we're trying to create here. We're trying to create an organized sector for primary care. And this is sort of came about when we realized OHTs are coming, and we needed to have an organized sector in order to really honestly represent primary care as a whole. As Gord said, we are the interim representatives right now. We're at the steering committee meetings, but we weren't elected. We don't have any real honest representation for you. We want to change that. So a group has been getting together every few weeks to talk about primary care issues by a small group of physicians that were and providers that were keen on trying to organize primary care. And it really started from that OHT kind of lens. And then March hit and COVID hit, and then it became a whole different animal. And we've had to deal with PPE distribution, how to practice with COVID, what is COVID, how to do flu clinics with COVID, and now we're talking about assessment centers, vaccination clinics, and the next phase of life for us. So it's been quite the impetus to make this organization happen. And Janet's been a game changer for us. She's been our transformation lead, really helped to get things going and keep our momentum from every one of these talks, or every one of these meetings. So we came up with this vision and mission to really talk about why we need to organize and what our intent is, what we want to accomplish. So if you just bear with me, I'll read it really quickly just because some people might be on the phone on this. So our vision is to be an inclusive network of primary care providers leading with a unified voice to improve the health of our community. And our mission is to create a strong and united primary care network to lead system change utilizing quintuple aim values, drive health equity and continuous quality improvement for the best possible experience and health outcomes, advance patient-centered equitable care in partnership with those we serve, and improve integration of primary health services with public health and other social and healthcare partners. So that's really the why. Like, why do we want to organize? We want to make sure we're consistent with our vision and advancing our mission. So now the next thing we're going to talk about is the how. Next slide there, Janet. So this is our proposed structure for the primary care sector. As I mentioned, the Primary Care Alliance is everybody that provides primary care in London Middlesex. whether you're an optometrist, a pediatrician. If that vision and mission speaks to you and you provide primary care, you're part of this group almost by default. And then we're going to create this executive group or primary care council, which will somewhat replace this leadership group that we've been using for these last year or so. And it's going to be elected, and it'll be representation based on distribution, which I will talk about shortly here. And then from that, we're going to be able to get true representation, representation for primary care at the Ontario Health Team, at the Provincial Primary Care Council, at any working group where they need primary care input. And it won't be just as it has been in the past, where there'll be some doctors that are interested and will get a tap on the shoulder and attend, and they'll say, I think this is a primary care physician, which is great, but it's not the same and not as powerful as having somebody saying, I'm here representing the Primary Care Alliance, representing 400 family doctors, taking care of 500,000 patients. And this is what we think we need to change, what we need to improve, what we need to target next. So that's what we want to get to. And that's what the whole purpose of this organization is. Next slide. So as I mentioned, we're trying to recreate or create this executive group and based on the representation by distribution. So we have data talking about all of the different physicians and providers in our area, like what percentage are FIG doctors, CHCs, FOs with a fit, FOs without a fit, walk-in academic nurse practitioners. So using those kind of percentages of our providers as a whole, we can then make our executive group reflect that. We also want to take into account rural and urban divides, make sure you have that rural voice. Next slide. So really that's what we are, as we want to become, and we're really close. With the OHT, we're trying to get this accomplished, to have elective representation by the end of March. So we'd ask you to sign up for these LMPCA newsletters if you haven't got them already. You know, we got a lot of emails, a lot of information coming at us like a fire hose. The newsletter is a great curator of information, so you make sure you don't miss anything. You'll get everything you need in terms of CME information you need to know, upcoming events. We want you to spread the word to your primary care colleagues. We'll be sending out emails in the next few weeks about this again, so share it with your colleagues and your coworkers. We'll ask you to attend LMPCA meetings. We're going to have quarterly meetings where you can express your concerns, talk about what you want to change, what you want to improve, and hear what's going on. And then when we do ask for these people that are interested in these executive council positions, please make your name known. We want to have a diverse, broad representation from all sectors, from all parts of primary care. So please let us know. And that is what I want to talk about LMPCA. Thank you so much for coming here tonight. We're really excited about the event and the feedback and the excitement we had. The registration numbers have been fantastic. And we hope to keep that momentum going, and looking forward to hearing this talk today and hearing everyone's thoughts. And I'll hand it back to Gord for introducing our next speaker.
Thanks, Vineet. So I'm excited to have our three speakers tonight. First off, we have Dr. Dominic Nowak. He's a family physician from Toronto, a faculty member of University of Toronto. Outside of his work in primary care, he recently has completed his Master's of Health Administration at the Institute of Health Policy, Management and Evaluation at the Dalai Lama School of Public Health. He works in primary care, healthcare system strategy, advises several Canadian organizations on health policy, and is grounded in science and compassion. And most recently, him and his partner tonight have led up the Ontario Primary Care COVID Vaccination Action Council. So we'll have Dominic speak tonight a little bit about the action group and how primary care fits into vaccination rollout.
Gord and everyone, thank you for having me here today. It's a pleasure to actually see this level of unity from primary care in a region. It's just remarkable. And I'll start just like Vineet with the why, right? So at the start of vaccine rollout, the organizations really noticed that there was no primary care voice at a lot of the vaccine tables provincially. And there was this need for an advocacy group for primary care partnership. And the organizations, all of us decided to come together as a united voice at the table with the vision that primary care, rather than the ministry and the task force and everyone engaging all of the organizations separately, that we could be stronger together as a united voice and vision for primary care. So that's what this is. That's what we call PCVAC. So the Ontario Primary Care Vaccination, we call it an action council because it's supposed to be very action driven and solutions focused. And we're not a formal decision-making body, but we advocate for primary care voice. Seeing that there is no primary care voice at the task force and these other vaccine decision-making tables. And then on the other side, we try to provide clear, consistent information to all the primary care professionals in Ontario. And that's, our team representing a sum total of 20,000 PCPs. So a very strong voice towards vaccine rollout, and a voice that in a regular year would do most of the flu shots in the province and should be also very much involved in planning for vaccine rollout. So I'll walk through 3 things here. First, I'll share with you how we've been pitching primary care for supporting public health leadership throughout the province in vaccine rollout. Next, I'll share with you some of our ideas around what primary care needs. And I need your help as well. And Noah and I need your help, and the group needs your help in sharing with us maybe after this meeting and during the meeting, whether some of the messaging is landing and whether there's any opportunity here for us to advocate for shared things that you're noticing in your region and then also in other regions. And then at the end, I'll also share what we're thinking provincially could be the opportunities for primary care to get involved now, but actually mostly in phase 2 and phase 3 going forward. And there are some models that we have in mind. I'd love your feedback around those. So first, primary care is ready to support efficient and equitable vaccinations. And we'll do this in 3 ways. So one is distribution, partnerships, and influence. And in the distribution category, we have 20,000 family doctors, primary care professionals raising their hands throughout the province, just like you are, saying we're ready to support public health leadership in the vaccine rollout. The Ontario College of Family Physicians also has a bi-weekly community of practice, which a lot of you, I think, join. I see a lot of names that are familiar from that. That's around 1,000 participants every 2 weeks. And if you go to one thing around vaccines regularly, that's it. That's kind of the one-stop shop to get a regular update. And then we think also that primary care, through our EMRs and through some of the population health things that we have in our EMRs, we could help drive some of those priority lists in our regions in terms of who should be getting vaccines first. Because when I think of my practice, there are probably a few people that jump up to mind who really need the COVID vaccine almost first and almost in phase 1 versus others. And then I think especially the groups like this can share learnings across these mobile teams, the larger hubs that you've already created very successfully as a group, and we've been sharing throughout the province as a kind of a beacon of hope for other regions where primary care is just as keen to get involved. And then on our end, we're working in unity with several other provincial partners, we'll call them. So the Ontario Hospital Association, very keen to support kind of a shared vision towards COVID vaccinations, the Council of Ontario Medical Officers of Health, and other provincial leaders as well. And then on their behalf, we also share messaging, right? So when there's some things that are common amongst the public health units, amongst primary care provincially, we share that in our email blasts. And that includes some of the tools we have around vaccine confidence that Noah will be speaking to afterwards. And some of these things are things like they're quite operational. Others are around engaging your communities. Others are in vaccine planning as well. And then yet others are things like letters to our practices. So I'll share with you some of those things in the next slide. So this is one call out to a resource that the Indigenous Primary Healthcare Council developed around engaging Indigenous communities with vaccine implementation. And they have an entire guidance document on this that we've shared with primary care professionals throughout the province. And I noticed that you have already amazing engagement plans that include Indigenous populations, but also primary care groups in your vaccine plan that your medical officer of health released today. And this is just another tool for that. And then I'll highlight the Center for Effective Practice as well. So this is a fantastic one-stop shop hub for everything you need to know about COVID-19 vaccines. And I see some of their leaders are here at this meeting today. So I'd encourage you, if you ever have a question around COVID vaccines or want to see patient resources or things like that, just go to the Center for Effective Practice as your one-stop shop. And then some of the other things, this is kind of a pitch for our email blasts through the organizations that we share are like this FAQ from the New England Journal of Medicine that we found very, very helpful towards COVID vaccines. We have patient letters that you could share with your practices as well. This is one from the Ontario College of Family Physicians. Another one updated last week from our group, the Primary Care Vaccination Action Council, other kind of knowledge translation and vaccine confidence tools. This is from the Waterloo School of Pharmacy. So we help curate some of these things for you provincially. And then here's obviously the community of practice from the Ontario College of Family Physicians, which you'll have seen, next one being February 5th. And then finally, we have some ideas provincially around what primary care needs to support, a world-class vaccination plan. And that you'll have access to this slide afterwards, but it comes down to good communication from the public health units and provincially, right, with specifics around vaccine supply, what unknowns are, how health professionals can get involved in each region. And I hear that your medical officers of health and public health units are fantastic in that sense for primary care engagement and keeping you informed. It also includes things like collaboration. So making sure there's a tight partnership between here, the Primary Care Alliance, and the public health unit. And then also anticipating what we'll need, right, several months down the line in phase 2 and phase 3. And then this logistical transition, which it may not be as relevant for your public health unit since you already have primary care very much involved from the start. But in other public health units, and certainly in some of the ones that might surround yours, there's right now a very hospital-focused strategy. But we're hearing from the hospitals and the Ontario Hospital Association, for instance, that hospitals are buckling up for high case rates, high ICU use, and everything like that. And actually, they want to be transitioning some of that work and some of that labor over to the community, the public health units, and to primary care. So this logistical transition from hospital hubs to hubs that are run with hospitals, but led by primary care as kind of the generals, or led by public health units, sorry, as the generals, and then primary care is that the professionals that are working on vaccine confidence, engaging with the communities, and actually putting needles into arms. And we have some clarity around the OHIP-H codes that you would have seen last week already around that, and then maybe some forthcoming clarity around some of that leadership funding flowing through the public health units coming in the next few weeks as well. I have my fingers crossed for that. The last part of this are basically 4 ways that we could see phase 3 working for primary care. And I think the point of this slide is for the group here to think about, what do we need here? Let's say this were to come true in March. What do we need to do before then for us to be able to help in all of these situations? So in addition to kind of our regular office-based and pharmacy settings, what do we need to do to make these come true? And the first one being these efficient mass vaccination hubs, which I saw in your vaccine plan as well, that was released today. Then it'll also be important to think of the folks who can't get to this hub, right? So I think of homebound older adults, shelters, other congregate settings, and expanding the mobile teams that are already working so well throughout the province, in partnership with hospitals and public health and primary care. And then finally, not everyone will have confidence in mass hubs or mobile teams run by large institutions. So how do you think of this community tailored lens, and especially thinking of groups that need special programs for us to be able to engage them properly? So I think of not only culturally tailored sites, but also places that have frequent outbreaks, or it's when you reflect on the pandemic response provincially, it's easy to see how people have a reason not to trust government and institutions right now. So how do you still make sure that we're vaccinating people in a way that's equitable and not missing big groups in our population, in our communities, because of historical failures where we've lost trust as an institution of medicine, or even recent failures in the COVID-19 response for certain communities. So I think I'll stop there. Again, the PCVAC is a voice for primary care provincially. Very glad to be here. We're not a decision-making body, but I very much welcome your feedback through this presentation. And then also afterwards, just email myself, email Noah, if you have any ideas for where we could advocate for something that your public health unit needs, and you could see other public health units and other primary care groups meeting provincially. Thank you for having me here today.
Thank you, Dominic. I'm going to move on to Dr. Noah Ivers. He's a family physician at Women's College Hospital and a scientist at Women's College Research Institute. He holds the Canadian Research Chair in the implementation of evidence-based practice. He's also an associate professor of the Department of Family and Community Medicine at the Institute of Health Policy Management and Evaluation at University of Toronto. His research focus is on the use of data to drive evidence-based patient-centered improvements in healthcare. For the past few months, he's been helping to lead the healthcare workers arm of a national coalition focused on data-informed behavior campaigns to end the pandemic, known as 19 to 0. And as we mentioned, he is also co-chairing the Primary Care COVID Vaccination Action Council with Dominic. Go ahead, Noah.
All right. Thanks so much for the intro. I want to talk to folks not about logistics, but about the things that you can do right now, even before we have vaccines available, to ensure that when we do have vaccines available, there is actually the kind of demand for it that we need to see. So this 19 to 0 coalition, which you can Google, you see the website at the top there from the screenshot, and you can play around on the website if you don't feel like talking to me or looking at my slides. We are a group of 300-400 people from across the province, representing we're nonpartisan, wide range of disciplinary backgrounds, working to try to increase vaccine uptake. And the evidence suggests that there are two key ways to increase vaccine uptake, and that is when people get recommendations from a faith leader and or when they get recommendations from a trusted healthcare professional. So all of you listening here today are absolutely essential. And I want to offer you 3 messages, and I want to talk to you about how you can follow through on these 3 messages. So message 1 for you in this pandemic response and the vaccine uptake is to get educated. You need to know the basic facts so that you can feel confident, obviously, in your own decision to get vaccinated, but also feel confident in being able to respond to the patient questions that I'm sure you're already receiving. And you're probably receiving questions from family members and people that are texting you and God knows what. I know I am. Number 2 is to get vaccinated, if medically appropriate. It's really powerful when a trusted professional says, yes, it was good enough for me and my family. Sometimes you're prepared for an argument and actually you let them know that and it all falls away, actually. And so not only should you get vaccinated if it's medically appropriate, but we're asking healthcare workers to, when it comes time that vaccines are available and many of your colleagues are getting vaccinated, to please let your patients know that you've been vaccinated, because that builds confidence. And then 3 is, it's not easy always to have these conversations. So we're asking you to take a moment to get skilled. And what we mean by that is that there are better and worser ways to have conversations with people about vaccines. And there are evidence-based approaches here that you can learn in a jiffy, especially primary care. This is it's kind of like stealing from things you do every day when trying to have conversations with your patients. I'm just going to give you a quick framework today for how you can apply it in an evidence-based way about the COVID-19 vaccines. So, I think first things first, I'm going to repeat this a few times. It is natural for you and or your patients or your family members to have concerns. It would be strange if you didn't. Vaccine hesitancy lives on a spectrum. The folks that are staunch anti-vaxxers are a very small proportion of the Canadian population, vanishingly small, very loud, but very small. The folks that are unquestioning sort of acceptors are actually much bigger, but they're kind of an unusual group also. The vast majority of Canadians have questions that deserve answers. This is a new thing. So, just because somebody has some questions, please don't judge them. And just because you have questions, I mean, that's great. Let's make sure we get them answered so that you can answer your patients' questions. And I'm just going to provide you some of my take on some of the common questions and answers so that you feel a bit better armed. And I'm going to quickly tell you about where to find more. As Dominic said, the CEP website is fantastic. I'm going to point you there. So, I think the predominant concern is about safety. And very commonly, people want the facts. Oh, what side effects can I expect? You know how to answer that. It's there on the slide. Basically, it's a sore arm. The thing that really worries people is that these vaccines are new. And so how do we know about long-term safety? And the way that we answer that question is we say the following. Vaccine side effects occur within 6 weeks of the vaccination in almost all cases. And that is why they planned the trial to be 8 weeks long. And we had more than 70,000 volunteers involved in the COVID-19 vaccine trials during the year 2020. All of them followed for at least 8 weeks. And so we actually have really good data about safety. The thing that we need long-term data about is how long the immunity will last. That's what we want long-term follow-up for. Not only that, but we now have 40+ million people around the world that have been vaccinated. Many of them have had follow-up for at least 6 weeks. And then frequently there are myths about whether it can give you infection. These are misunderstandings about the way the vaccine works. You can address these. I'm sure you can. So these conversations are nothing to be worried about. You can do this. Number two is, was it rushed? We hear that all the time. And I think, you can use a figure like this, but you actually don't need to. The things that I tell people when they bring up, the idea of rushing is that there's a difference between going quickly and rushing. Rushing is sloppy. No, nothing was sloppy here. No steps were skipped. In fact, these were larger trials than those we normally see for vaccines. When you put them together, they were 10 times larger than for any vaccine experiments done in the past. So we actually have heaps of data, way more data on these vaccines than we have for normal vaccines. And then people want to understand the mRNA. Can that go into your DNA? And of course, no, it can't. And you're going to want to have some practice in how what is your spiel around how mRNA vaccines work? And I'd urge you to just take a moment tonight or tomorrow or at some point soon, because you are going to get these questions. You want to figure out what your spiel is to respond to it. And I often tell people, did you know every minute of every day we use mRNA to make protein? And that's what we're doing in this vaccine. And every moment, every day, that mRNA and that protein is then dissolved. And that's what happens with this vaccine. So it makes the protein, our immune system sees it and responds, and all that's left after is the memory. Everything else dissolves. I already talked to the long-term protection question. The truth is we don't know, but when that comes up, I try to emphasize that we actually don't have full protection until about 2 weeks after the second dose. And that is why it's really important that people follow public health guidance for now, and even for the time after that until we get more data about transmission. So the CEP website has already been pointed to. It actually has amazing resources that can give you these tidbits that will be useful for you, I think and hope. In particular, there's this wonderful FAQ thing that sort of goes through the questions and answers that are most common out there. The other thing it does is it gives you on that website, there's a framework for how to have these conversations. I just want to spend 2 more minutes around that, and then I'll hand back the mic because I don't want to monopolize time here. I'm sorry. But what I want you to know as primary care professionals is that you are it. You are the most trusted healthcare professional in people's lives, the lives of your patients, and also the lives of the community members that you interact with on Zoom or wherever else. People know that you are a healthcare professional, so you're it. We are desperate for you to play a role in building vaccine confidence. And when you interact with people with the vaccine, and we ask you to do that proactively, assume that they're going to take it. Say things like, I took mine, or I'm going to get mine when I get a chance to, depending on when you're talking to them, and say, I'll be happy to let you know when I know more about when it's available to you. But also at the same time, remember, as I said at the outset, it is normal to have doubts or concerns or questions. It would be strange not to. So what we want to do is build trust and credibility. Let people know you've done your reading. You've gone to webinars like this one and others. And so, you know, you want to invite their questions, not dismiss them. And so this is what I want to leave with, is that this is one more resource that's on the CEP website. And this is the framework which is evidence-based for interacting with patients or family members or whomever. You know, we all have that strange uncle who might bring you questions about the vaccine. And I think what you want to do is take a moment to, you know, after you proactively bring up the vaccine, you know, establish your credibility and offer the provision of information. You can see on this sort of PDF, there's some example talking tips, but you're going to want to make this your own. And, you know, primary care professionals are so good at this. We just thought we would put it out there as some examples. And so, you know, you definitely want to tailor the recommendation. You know, it turns out, Uncle Joe, you are high risk because you've had a heart attack before. And that really worries me, because if you got COVID, you know, it'd be trouble, I think. And then towards the end, you want to briefly address their concern. So even if they start with the concern, they say, you know, I heard it got rushed. You start with saying things like, you know, you establish a credibility, you know, I've been reading a lot about this. I'm going to get it myself. Can I tell you some of what I know? Here's why I think it's a good idea for me and for you. And then you circle back to their concern. You don't just dismiss their concern right at the outset. So that's the sort of take-home message I want to offer you to. And that's basically what I wanted to cover. And as Dominic did so well, like, I just want to invite people to join the team. Like, we desperately need everybody to talk to their patients and their communities and make a little bit of difference. There is right now enough people that are declining the vaccine who are being offered it, that we will not get to herd immunity unless we all band together to build vaccine confidence.
Thanks, Noah. And I'm going to just highlight the precarious choice of words of vaccine confidence versus vaccine hesitancy. And so as I heard that maybe the first time about 10, 14 days ago, I've managed to be able to change my terminology. And I think we all also need to look at that as just a way of thinking how we're trying to promote the uptake rather than dealing with the frustrations that we have. It puts in a more positive spin. I'm going to move on and introduce Dr. Alex Summers. Dr. Summers is the family physician by training, and he's also the Associate Medical Officer of Health for the London Middlesex Health Unit. I'm sure Alex would have never thought, as being a young medical officer of health, that very early in his career he would be dealing with leading pandemic work. I don't think all medical officers of health would have never thought they would have experienced that in their lifetime. But in my opinion, he's done a great job for our area in London Middlesex, and we're happy to have him speak tonight about the vaccine rollout in the London Middlesex area.
Thanks so much, Gord, and my slides should pop up there in a moment, I hope. Just a delight, as always, to join the primary care community in our community and in our region, and to see the excitement and the enthusiasm and the willingness to be part of this is inspiring for me. So thank you for your ongoing leadership moving forward collectively, and for your leadership to date. It's just been remarkable. The Middlesex London Health Unit, Chris Mackey and myself, we are lucky people to be able to work in a community full of leaders such as yourself. So thank you. It's also great to be speaking with Noah and Dominic, and your reputations precede you. Thanks for your work in leadership at the provincial level. Noah, you've given us the next lyric for like a major pop song. All that's left is the memory, everything else dissolves. That is, oh boy, that's a good one. I think that might sum up some of my previous relationships, frankly, but we won't go into that tonight. We'll just say that that's going to go on a t-shirt someday. I love it.
I actually want to hear more. Can we skip the rest of the?
Yeah, you know, that's for later, man. That's for later. I think you know my friend Ja pretty well. He can give you some of that detail at some point. But regardless, a delight to be with you both, and to be with everybody today. So my objective today is to give an update on the COVID-19 vaccine rollout here locally in the context of the provincial frameworks that are evolving rapidly, and also take a moment to just pause on a remarkable year. The first reported case of COVID-19 in our region, first in the country and first in Ontario, was a year ago. We received that report on the 24th of January at the health unit. There was repeat testing and verification of a million things, so it wasn't released publicly for a couple of days after that, but it's been a remarkable year. And now, remarkably, we have a vaccine. And with that, we need to celebrate some of this. So I want to highlight some of the provincial landscape that frames where we are today. Ontario's COVID vaccine program is going to happen over 3 phases. Noah and Dominic referred to those 3 phases. All of the phases really reflect the escalating availability of vaccine supply. And that escalating availability will allow for us to reach greater and greater numbers of people, building confidence in that vaccine along the way, we hope. And at each different phase, different strategies will be necessary in order to make sure we're getting the vaccine to the people that we need to get it to, in order to optimize the impact on morbidity and mortality. So with that, over the early stages of the rollout, there's been a whole lot of clarification along the way of who's doing what, and that's going to continue to happen. At the moment, the role of Middlesex London Health Unit of MLHU is to have overall responsibility over that COVID-19 program, executed critically with everybody in our community. The success of this program hinges on our ability to collaborate and to engage, and I hope you will see our commitment to that unfold each and every day. The vaccine plan for our region has been articulated in its draft form through the health unit. It's now available online, and there's some opportunities to provide feedback. And so I would really invite you to review it. It's available through the MLHU website to see what makes sense to you, what doesn't make sense, and to provide that nuanced feedback that will allow for us to make sure that we are doing and preparing in a way that serves our community the best. So please, 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 I invite you to review it. Some of this stuff you can scan through. The details are growing and emerging as we speak, but the general framework is certainly beginning to come into play. And this interaction here, the ongoing collaboration with the Health Alliance, the Primary Care Alliance along the way, it will be essential. So critical in that plan, and one thing I want to highlight is that across the province and here locally, there will be different vaccine delivery strategies at different phases of the vaccine. Phase 1, as we are in right now, is defined by a scarcity of supply. The major hospital centers across the province were tagged with that initial rollout for a multitude of reasons. That is transitioning relatively quickly to the public health units. We are really fortunate here in our region. London Health Sciences Centre has, and I mean this, has been a remarkable partner and very, very oriented on ensuring a community and not just hospital-centric approach. And I'm really, really grateful for them for that. So the phase 1 is the initial max vaccination clinics as a place where people can come to get vaccinated, and then the rollout of mobile teams. Here locally, those mobile teams have been staffed with public health unit staff supported by the Middlesex London Paramedic Service, as well as support from on-site staff at large facilities, predominantly, of course, retirement homes and long-term care homes. And I will mention our progress here to date in a moment. Phase 2 will be largely defined by additional mass vaccination clinics with partnerships from London Health Sciences Centre, Middlesex Hospital Alliance, and others. That is a growing thing as we speak. We are currently in the process of ensuring that we have additional sites for mass vaccination clinics, likely to be up and ready to go for March, kind of ready to receive vaccine whenever it can arrive so that we can get it out the door as soon as possible. The role of primary care in this, I think, is something that is continuing to evolve. And as I've mentioned before, there are still lots of unknowns through all of this. And part of being able to be here and communicate through Gord and others is to make sure that you guys know what the unknowns are and that we're not holding anything back by any means. Phase 3, pardon me, is really when supply is readily available. to all who want it. And that's where the role of primary care clinics, as Dominic mentioned earlier, and pharmacies as well, potentially, again, that's evolving, will begin to play an important role. Last year, in the fall of 2020, we distributed over 100,000 doses of influenza vaccine to primary care in the Middlesex and London region. And to me, this highlights so truly the tremendous potential and willingness of primary care to participate in the delivery of the COVID-19 vaccine. We are very aware of the readiness when the vaccine makes sense to do so for primary care to deliver these vaccines in their clinics, and it's an integral part of the ongoing rollout of this product. Primary care, though, will play a critical role at all phases, and Noah and Dominic have commented on this, addressing vaccine confidence, and thank you for the new terminology that is evolving, and I'll make sure I get that right moving forward. The ongoing assessment and management of adverse events following immunizations, as always. I saw Kathy had a question there about how reporting for that works. Reporting will always go through the health unit. It's the same for all AFI reporting for other vaccinations as well, where it is a reportable condition to the health unit, and we consolidate that as a surveillance measure. With the new availability of of the COVAX system, which I'm sure some will have questions about, we will be able to look, I hope, at AFI reporting through that system. And then obviously the broad distribution of the vaccine in that phase 3. Here locally, the primary care COVID-19 vaccine task force has been mobilized, and we continue to have ongoing conversations about what that will look like. And just great to have them on board in anticipation, not only of phase 3, but of every step along the way. Somebody's drawn on my slide, which is great. I'm very impressed. Where we are right now, we are still in phase 1, and because of the scarcity of supply, the focus remains on congregate care for seniors, staff, and residents of long-term care and retirement homes. Healthcare workers, First Nations, Inuit, and Métis populations, and adult recipients of chronic home care have been initially tagged as part of phase 1. As we're realizing, phase 1 is a series of phases within a phase. And so we will anticipate more direction from the province on this. The reality is that early on, as you are all aware, and I'm sure you're getting lots of questions from your patients, the demand for COVID-19 vaccine supply will certainly exceed the actual availability of vaccine. And so ongoing prioritization will be necessary for all cohorts and for healthcare workers as well. There is a stepwise approach that's being developed and optimized and modified and fine-tuned at the province and implemented here locally within that context, depending again on the supply. We have locally something called the COVID-19 Vaccine Prioritization Advisory Committee. This is a advisory group for MLHU here on Perth Public Health and Southwestern Public Health, which covers Oxford County and Elgin County. That within the context of the provincial guidelines provides additional prioritization details. Essentially, the province sets this very narrow network, and then if we have to do additional prioritization because we only have so much available to use, we have to do that, and we do that based on the advice of this group. All the details around the vaccine prioritization process are available online, the terms of reference for the group, the representation of the group. At the moment, you can check out that membership. I chair that group with good representation from primary care, including Gord Schachter, Paul Gill, Scott McKay. So we are ensuring that there is primary care representation at that group. Every week, we also publish a memo to keep people up to date on exactly where things are at when it comes to eligibility, who's up, what's happening, and those memos are published here as well. The next one will be out tomorrow. So in closing, before we hit questions, I just want to highlight where we are to date in the Middlesex and London region. We're delighted to say that effective Sunday, all long-term care home residents had received, those who are eligible, received a vaccine. As of tomorrow, all high-risk retirement homes will have received their first dose. The Western Fair Agriplex Clinic, which is our mass vaccination clinic, had to close because we don't have enough supply to do any additional first doses, but we'll be reopening in order to continue to deliver those second doses to people who received a vaccine in that first wave. And we are in the process of at least initial site selection for additional mass vaccination clinics. and the works that go along with it. So things are moving very, very quickly. We are somewhat kind of held back at the moment because of the delay in Pfizer supply. We have not received any Moderna in our region. A Moderna was targeted for other higher incident rate places across the province, as well as for the north, which is great. So we are with Pfizer, and obviously the Pfizer slowdown impacts the entire country and us here locally as well. So as that starts to ramp back up, so shall too the needles in arms and out the door. So looking forward to that very much. That's all I've got to say. Looking forward to some questions. I'll stop my sharing and hand it back over to you, Gord.
Thanks, Alex. And I thank all our three speakers for being succinct and on time. It gives us some time for some questions. I know that both Noah and Dominic have other commitments at 8, so we'll try and address some of those questions for them first. But I think we'll kind of use it as a panel. I'm going to ask my colleagues, Phil, Julie, and Mario, to kind of lead some of the questions. And maybe what I'll do is I'm just going to ask one of you to read out. We've had a number of questions that were sent to us beforehand, and the odd one in the chat room. So Mario, maybe I'll go to you and ask you to read the first question out.
Sure. So question was asked that every provider has had a question around vaccine availability and the limited supply to date. We know that things are evolving quickly. So as of tonight, Tuesday, January 26th at 7:48 p.m., what insight can you give to providers as to what has limited supply to date, both regionally and provincially? And provide insight, what's been widely reported in the media. If you guys have any private insight, I know you have obviously connections in the province. And do you anticipate our case counts that have come down over the last few weeks may affect our relative supply compared to other regions of the province?
Alex, do you want to address maybe some of those?
Sure. So let's get granular on supply. We received no additional Pfizer vaccine this week. We received 2/5 of what we were anticipating to receive last week. And next week, we anticipate we'll receive 2/5 of what we were originally targeted to receive. So we are pooling all our vaccine together with Huron-Perth Public Health Region and Southwestern Public Health Region, because we determined that we're so integrated already that we are going to ensure that we are all covering our bases collectively. So that is where we stand. We will have in the hundreds of doses available at the end of this week, and we will start doing second vaccine doses into long-term care home residents next week in anticipation of supply improving somewhere around the week of February 8th to February 15th. And we need that to improve so that we can get second doses into arms for those who originally got their dose within that 42-day period that is necessary. So it's tight, like super tight. Vaccine, Pfizer is going to be redistributed all over the province to make sure that everybody can honor the second doses that were already delivered and to achieve the objective of vaccinating long-term care home and retirement home residents. There was a really helpful and kind of anticipated release from the scientific and advisory group at the province, which indicated that the quicker we vaccinated long-term care home residents, the quicker we would avoid cases and most critically deaths. So the whole shift has now been how quickly can we get those folks vaccinated. We're there here, which is awesome, and we just need to get those second doses in. The quick last question, I know you asked about whether or not our case counts will influence our ongoing availability of vaccine here. I don't know the answer to that question. I do not think so. I think the time for unequally distributed vaccine across the province is likely gone. I think it's likely going to be triggered by essentially consistently achieving all the targeted groups at this point.
Perfect, that's great. And follow-up question, give us a sense of your understanding of the upcoming timelines for the various vaccine options. Again, as of tonight, I know this is very much a moving target. So again, whether the Johnson & Johnson will affect things, Astra-Zeneca, does that change the phases here in London Middlesex? How do you guys kind of envision that happening?
The more vaccine that we have at any given time, the more quickly we'll move from phase 1 to phase 2 to phase 3. essentially, if we got more vaccine than we know what to do with, it's opening up the floodgate to anybody who can give that vaccine. Part of it is also related to the stability and ease of use of those vaccines. Pfizer is particularly bare to use, or at least to store. And so hence the need to kind of have a bit more of centralization around its administration. Moderna gives us a bit more flexibility. The idea is that Astra-Zeneca will give us more. I would say it's very, I have no inside track on any of this. It's interesting that Astra-Zeneca is taking a bit of a while for approval at the Health Canada level. I don't think it's necessarily from concern over the safety, but probably I think the effectiveness of AstraZeneca, relatively speaking, but who knows? It's just taken a little bit. Johnson & Johnson, obviously having a single dose vaccine is like a total game changer. So we'll see. That's a roundabout way, Mario, of saying I don't know. But obviously as more supply comes in and more options get added to the table, the more quickly we will move through the different phases.
Perfect. That's all. Thanks, Alex.
Thanks. Julie, do you have some questions?
Yes, I'm interested in asking for more information about how to engage our hesitant patients or people that we know who are healthcare workers or work in other high-risk settings. What do you think will be the mandatory vaccination policies? I guess two-pronged. We're interested in knowing what the government, what perhaps someone like Dominic would like to see the government enforce as a mandatory policy for these settings, and also from Alex's point of view, what will the public health department be enforcing as mandatory policies? What will be the consequences?
Dominic, any thoughts?
I'd like to hear Alex's thoughts first, and I'm copying out a little bit because I don't think, you know, I don't know if there's a clear sense of where this is going yet. We've had some conversations in other health policy hats around, you know, what the legal frameworks are and what the precedents are and everything like that. And you know, mandatory vaccination is controversial. There's this responsibility of the employer to offer accommodation. Even if they have kind of a policy that has, you know, everyone here should have a vaccination, they have to have some kind of reasonable accommodation for those who can't have it, or for whatever reason that is. And I think that's where the conversation has ended so far. Alex, I'm not sure if you have any other top-ups. You would probably know more of the inside scoop for what's going on in Ontario public health.
Yeah, you know, the conversations around mandatory vaccination have well preceded the arrival of the COVID vaccine. And I do not anticipate that COVID-19 vaccination will become a mandatory thing, frankly. I think the appetite for mandatory vaccination across the board is often quite low for a variety of different reasons. In Ontario, where we've kind of ended up historically, at least for childhood vaccination, is something that I've heard best described as mandatory choice. And that's always a place that I would love to get to with the COVID-19 vaccine. So for kids, in order for them to go to school, in order for them to be in compliance with what's called the ISPA, Immunization of School Pupils Act, you have to make a choice about whether or not you're vaccinating your kids or not. And that mandatory choice really pushes people, because the majority of people, when actually given the choice of saying either vaccinate your kid or don't, but you have to tell us and you have to make a choice, are going to say, you know what, I am going to vaccinate. And that's why we have like well over 90%, if not higher than that, adherence to the ISPA in our region, is because people have to choose. You can opt out, but you have to choose. And I think if we head anywhere, it'll be more towards that, what I would describe as mandatory choice as opposed to mandatory vaccination. I think the big push will be on vaccine confidence. That will be, I think, a major initiative. We're building local capacity here as a health unit with some of our promotional materials here because of the work that's happening right here, right now at this meeting. But I think it would head more in that direction as opposed to actual mandatory vaccination. I don't have any inner scoop, but I would put a little bit of money on that.
Thanks, Alex. Just for everyone who's aware, Noah had to leave us. He has another talk at 8, and I know Dominic will be leaving shortly, but we're still going to continue. Phil, I think you had some questions there.
Yeah, so probably more for Alex and for anybody else here on the panel. What are the settings that public health is considering for smaller hubs of vaccination in phase 2 and phase 3? Would group practice spaces be considered? how is public health working with primary care to receive suggestions and input? Does public health need information about local resources, or are they aware of all the local resources?
So taking those one at a time, and maybe not in the order. So in terms of engagement, we have a planning table, again, here in Perth, Southwestern, Middlesex, London, that's meeting weekly, London Health Sciences as well. We have representation from the London Middlesex Primary Care Alliance in the form of Gord Schachter, who sits on that group. We also will continue to meet, or I will continue to meet or take input from Gord and others, including yourself, from the task force as they continue to mobilize. In terms of site selection, some of this, and here I am aiming for as much transparency I can, there will be a site in the county, I guarantee that, and there will be probably 2 additional sites in addition to the Agriplex in the city. The only reason I can't tell you when is there's active lease negotiations happening at the moment, and so I can claim the 5th on that one just because of the lease negotiations that are literally actively happening. The criteria for selection actually are detailed in the vaccine plan, which is currently public as of this afternoon. Part of that vaccine plan is also a survey, a check market survey that we hope we can solicit input, not just from primary care and healthcare, but from literally anybody else who's got ideas, input, and feedback on how we're going to do this. So our hope is that both through the feedback from that vaccine plan, as well as through the intersection with LMPCA, the prioritization group, and our ongoing alerts, newsletters, and webinars, that we are well plugged in. So what I can tell you, there's a hub coming to the county, I can guarantee. There'll be 2 more coming to the city, and we're just trying to sort that all out.
Thanks, Alex. I'm going to do one more question from our chat, and then we're going to go into the breakout groups. And I apologize to those of you who put questions in during your registration, but we are obviously have some limitations in time. Vikram Dalal has put a couple questions that are sort of related to the Pfizer vaccine. And I was sure to read out the first one. I said, it's not true that the Pfizer vaccine needs to be stored at -70, but once thawed, it's stable at refrigerator temp for 5 days. Shouldn't this not help with getting them into the arms of people with relative ease, as it does give us some time to get needles into arms? And I think on follow-up that, he was saying, I'm not entirely sure how long the vaccine once thawed is viable, but at this point, the limiting factor is supply. So will that allow us to help with that in some way, I guess?
Looks like Dominic is dropping off, so those questions are going to come to me regardless, I think.
Yeah.
So the Pfizer vaccine, there's a few things. So it's around both when it's frozen as well as limitations on movement. So I think we will get greater comfort and greater direction from Pfizer as well as others around how often this thing can be moved. There was a comment that Noah made about it kind of being a martini, the opposite. Like this is not something you want to shake. So there is these ongoing logistical limitations that I think and anticipate will get easier. So the excuse of not being able to mobilize Pfizer, you've already seen that that's changed, where we went from no forward deployment to forward deployment. And we are going to slowly be able to get into being able to move it even more readily to other administration sites. Certainly the desire is not to move it very much because of the potential instability of the virus, of the vaccine itself. The other reason for mass vaccination clinics, though, in terms of having like primary hubs that are in place, is to help utilize a scarce supply and have fairly good control on what's coming in and what's going out, and being able to ensure that a queue is formed and a queue is accessed and all that type of stuff. So, but regardless, specifically to that Pfizer vaccine, I think we will see changes in that over time.
Great, Alex. I wasn't going to go right to breakout, but there is one question there that I think would be worthwhile people to hear a little bit more about. And this kind of goes related to prioritizing within a phase, so which is the work where the priority task force is doing. So can you comment now on the priority of community healthcare providers in home care and the congregate settings of places like PHSS, which is, I forget what that stands for. It'll come to me.
Yeah. No, for sure. So
Go ahead, Catherine.
I was just going to say PHSS is Participation House or any of the community services agencies.
So adults receiving chronic home care services or other congregate settings are explicitly linked, named both in aspects of phase 1 and phase 2. I would say that those originally named groups within phase 1 and phase 2 is also evolving. Quite frankly, Mike Silverman and I were talking about this at length at a meeting today with Gord as well. The most predictive factor for a poor outcome from COVID-19 is age, full stop. And so more and more, there's recognition that both age is the most predictive factor for a poor outcome, but that it is also probably the easiest way to determine who should be in queue and who shouldn't be, because all those other things are a bit more challenging to get people into queue or get people out of queue. So I think the ongoing eligibility and prioritization across the province is still an evolving situation. However, I will say that we are meeting actively with the LIN folks who oversee chronic care, and we are aware of the desire for home care, and that happens in multiple forms. And so when that we will get direction from the province, and when that happens, we will make sure that that's implemented, and we're planning ahead that should that come sooner or later, that we have a model to go to meet people where they are, being a priority. So yeah, on the radar would be an understatement, as are a number of other things, but the ongoing formation of that queue, who goes first, who goes next, will be highly influenced by age and highly influenced by provincial direction.
Alex, I was looking quickly through the chat. There was another question there that I thought I wanted to briefly, and I hadn't heard this today. Apparently there was something with the European Union today announcing that they were wanting Pfizer to prioritize the EU first before other countries. I wonder if you can comment on that and how you think that could affect us here in Canada.
I'm a few levels removed, unfortunately, from those discussions. Yeah. So I have no idea. I think that I would not want to be the CEO of Pfizer right now, although I'm sure his stakeholders are happy, but shareholders are happy. But yeah, I have no clue. I think the ongoing global demand, some of it is demonstrative words, some of it may actually have meaning. I don't know. Pfizer has evidently committed to the federal government that by the end of March, the supply that was promised and that was secured through contract would be delivered to Canada.
Fair enough.
But who knows?
All right, so I'm going to get us to break out into the breakout rooms. And
our speakers for speaking tonight, and to the organizing committee for helping to bring us all up to date on the state of affairs in Ontario and more local as well. So Vineet, I want to thank you for talking about the London Middlesex Primary Care Alliance, or as I like to call it, the Middlesex London Primary Care Alliance, only because I'm a little biased in terms of being a Middlesex doctor, but we do truly love our London docs as well. Dominic certainly gave us a lovely presentation about the advisory group that speaks really on our behalf for about 20,000 primary care physicians, and they drive, they are sort of working on things that we can do as primary care physicians, such as driving our priority list for our EMRs, working with the Ontario Hospital Association, the Council of Ontario Medical Officers of Health. He mentioned the Centre for Effective Practice, which is a great resource. And for those people who have not had a chance to go to it, I would truly recommend that you do it. They have all sorts of resources, not just on COVID, but on lots of other things. I was first introduced to the site by Nicole Seymour, who was on the call earlier. I don't know whether she's still there, but she introduced me to that site, and I use the site all the time. They also work with, of course, our Ontario College of Family Physicians, for those of us who are associated with them. And I think he certainly indicated that the most common thing that we will be doing is being a part of phase 3. And I think we're going to have to think about how we can be part of that phase 3. So a lot of it may still end up being mass vaccinations, but there may also be mobile teams and mobile units. But I think we're going to have to sort of figure out what's best for our communities of practice, because there are some people who cannot possibly go to even the mass vaccination clinics. So we're going to have to figure out how to get that vulnerable population. I think there was a few comments in the chat group about what we do with people who are getting chronic home care. Where do they fit into the whole system? Are they, priority in phase 2? Are they priority in phase 1? Where are those kind of people? Noah Ivers talked a little bit about, or a lot, I guess, really about vaccine confidence, vaccine hesitancy, and just the general sense that we sometimes have uncles and all sorts of people who ask us questions nonchalantly, and that we need to be prepared to talk to those people about their mostly hesitancy and not necessarily completely against the vaccine. So we have to try to educate ourselves, get vaccinated ourselves, and be role models and that sort of thing. And that we should get quite skilled at figuring out how to have the conversations with people at wherever stage they're sitting at. So I think there's a lot of places that we can certainly see ourselves as primary care practitioners, being able to contribute to the whole vaccination process. Alex Summers, Dr. Alex Summers gave us a wonderful overview, and I think a fairly honest overview of where we are locally, why we're not getting more vaccine, how we're trying to distribute that vaccine fairly, and basically can't give us a timeline as to when the majority of primary care physicians will be able to be vaccinated, but certainly as soon as the supply is there, it sounds like he wants to get it into our arms. So looking forward to that. So I want to thank everybody for participating, spending the last hour and a half of your time with us. I think on behalf of our whole organizing committee, we're very thrilled with the numbers of people that were able to come out and spend some time.